Good day. This presentation is entitled Stepping from the Lab to the Patient, Lessons from the Glycocalyx. Although this layer was postulated more than 70 years ago, it's only recently that we've realized the physiological importance of this layer in terms of how fluids move in our bodies. There are 5 questions we're going to be covering. Before each question, we will climb a flight of stairs as a representation of our search for knowledge. We will reach a door. The degree to which this door is open reflects how much we know about the subject. Let's begin and climb our first flight of stairs. We reach a door which is ajar. What is the glycocalyx? The glycocalyx is a gel-like matrix. It lines all our blood vessels and determines the vascular barrier, preventing the free movement of water and electrolytes. If we look more closely at the glycocalyx structure, we see that it consists of proteoglycans carrying glycosaminoglycans attachments. But on its own, it's relatively functionless. It needs to interact with the plasma proteins and form a tight and negatively charged meshwork that controls the free movement of fluid and electrolytes. Here we have an example of the difference between an intact glycocalyx and one that has been destroyed. The endothelial surface layer is created by the binding and intercalating of these plasma constituents with the structural elements of the glycocalyx. Albumin is critical as a component in the normal functioning of the endothelial surface layer. What about the subendothelial layer? Adamson et al. Suggested a small space situated directly beneath the endothelial surface layer, which remains practically protein and charge-free. And maybe this is what actually controls the inwardly directed oncotic gradient that keeps fluid where it's supposed to be. Why is it important? The glycocalyx is very important in maintaining homeostasis in the body. It controls vascular permeability, the transmission of shear stress across blood vessels, and also plays a very important role in cell wall interactions. It is, however, easily damaged, and there are several things that can damage the glycocalyx. Here are 5 of the more common causes, and you'll notice that all of these are encountered in our critically ill patients. But take particular note of the last 2, hypovolemia and hypernatremia. Both of these can be caused by the type and amount of fluid which we give our patients. When the glycocalyx is damaged, it of course results in significant problems. And we can see from this list that the problems caused result in the type of patient that we often see lying in our ICUs. So let's move to our third question now. How do fluids really move in the body? We go to a room with lots of closed doors and we realize that we don't have all the answers here. But let's go through the open door. First of all, let's deal with Starling's principle. Now, we're all familiar with Starling's principle that describes a balance that occurs between inwardly directed oncotic pressure and outwardly directed hydrostatic pressure. There's a net filtration from the arteriolar side to the venous side, and with the excess fluid being reabsorbed via the lymphatics. But in fact, this is not entirely true. This is reflected by the low lymph flow paradox, the phenomenon that the vascular barrier is still competent even when the interstitial oncotic pressure equals that of the vascular lumen, and the colloid osmotic pressure paradox, where it is not primarily the intravascular colloid osmotic pressure which determines the power-limiting transvascular fluid loss. Rather, the issue may be the type of colloid active at the endothelial surface. In reality, very little filtration actually takes place, and the little filtration that does take place on the venous side. So now we must question some of the myths about fluids. Firstly, our patients are not always preoperatively hypovolemic. Secondly, surgery does not always dramatically increase insensible losses. The classic third space, represented here by a magician's disappearing box, was never localized and only quantified, and does not really exist. And lastly, even healthy kidneys take days to manage volume overload. The truth of the matter is that the body aggressively protects intravascular volume, and fluid accumulation will occur if given to normovolemic patients, even if it is a colloid. So how do we go about protecting the glycocalyx? Well, a variety of things have been looked at, and some, like antithrombin 3, have been neatly demonstrated to protect the glycocalyx, with image C representing an animal that had been pre-treated with antithrombin 3 prior to ischemia and reperfusion. Avoiding hypervolemia remains very important as it prevents the release of atrial natriuretic peptide, which causes degradation of the glycocalyx. Even sevoflurane has been shown to protect the glycocalyx, and maybe this is why it has some cardioprotective abilities. What we really need, however, is to be able to measure the damage, visualize the glycocalyx, and then give something to treat and restore the glycocalyx. And possibly the science of glycomimetic therapy is what holds the key. So in summary, what do we actually do? Well, firstly, we need to avoid hypervolemia. The question of colloids or crystalloids is an important one, but maybe just as relevant is the amount of fluid and what's in your fluid. Avoiding hypernatremia is an important aspect of protecting the glycocalyx. Remember the context of your patient, let's dispel the myths, and let's think again about albumin and how it can play a role in protecting the glycocalyx. And let's remember, don't harm the glycocalyx. Hypervolemia can be just as bad as hypervolemia for our critically ill patients. And maybe we need to move away from discussing restrictive and liberal strategies of fluid management and rather adequate versus liberal strategies. Many doors remain closed, but hopefully in the near future we will move to a situation where we learn to protect the glycocalyx and better manage the fluid strategies in our critically ill patients. Thank you.